Should be recording now. Let me share. You can see the first slide, yeah?
Yes.
Great, fine. Okay, let's start. So welcome everyone. I'm Mustafa. I'm sure you had a chance to read the slide now. I'm very involved now in supporting people in their exams, whether it's FRCOphth or if it's FRCS, or even other exams like FIBO or local exams like the Pakistani exams, the Indian exams, any exit exam basically, because it's relatively the same structure. Yeah, so it's the same sort of curriculum of ophthalmology everywhere in the world, obviously. And but my main focus, being an examiner at the Royal College here in London, my sort of teaching is focused on FRCOphth. As lots of you might be aware, the structure of the exam is quite different. So I'll try and split the talk today. It wouldn't take an hour or two, hopefully. I'll split it into a few sections. So first, I will speak about the differences between the exams. Yeah, so because lots of people are actually within this group is sitting the FRCS exam, and maybe in the future sitting the FRCOphth. So, and other people are just sitting the FRCOphth, and some are actually sitting both. And then and some are still starting the journey. So some people are not, they want to come to the UK, they want to start chasing up the college exams, and they just want to get an insight about the whole thing. And everyone is welcome, obviously. Fine. Lots of people are getting in. Okay. And then the next part of the talk, I will again discuss some learning material. I'm sure lots of people have heard about them, but I would suggest, that would be my personal opinion, to just focus on those. So with those exit exams, it's not about the amount of knowledge that you've got, because that has been tested thoroughly before. So in the MCQ exams, that's the theoretical bit. Now they're testing the practical bit. So it doesn't matter how much knowledge you know. It's about how to present it, how to structure your answer, how to think broadly, how to be safe, and obviously how to examine the patients. Good meeting. Sorry, let me just. Lots of people are struggling to get in. Okay. Sorry. Fine. So let's start. And I don't mind if anyone wants to stop me and ask questions. I don't mind. Okay, as we go along, I'd rather do that rather than just save everything at the end. Sure. Come on. Okay, fine. Some people are struggling to get in. Anyway, you'll be. There you go. She should be in. Okay, so FRCOphth, that would be our focus. And then there's the FRCS Glasgow, and then the FRCS Edinburgh. Yeah. So whoever is out there planning to sit any of them, or still starting their journey, they want to come to the UK, you must understand that the main difference between these exams is that the FRCOphth is the main one that you need to basically become a consultant in the UK. Okay, you cannot become a consultant without FRCOphth. You can relatively be a locum consultant, which is fine. Lots of people are locum consultants without the FRCOphth at all. But obviously, the FRCOphth, because it's very recognized here in the UK, it's got a high weight in your CV. Especially if you want to be a substantive consultant. So a substantive consultant, either obviously through the normal training program, with the CCT, or through CSER, which I went through, and you have to do the FRCOphth to get CSER. You cannot get CSER without FRCOphth, although it says, it's really advisable, it's highly recommended, it's mandatory, okay? In the past, I think they used to sort of consider FRCS, and very, very few people managed to get CSER without FRCOphth, but with very, very high difficulty, because they needed to get lawyers to support their application, and it was a big deal. So basically, just you need the FRCOphth, okay? Others do not need the FRCOphth if they're chasing to become locum consultants or maybe specialists. You would still be a very senior level clinician, but you will not be a substantive consultant. Okay, so I'm just addressing whoever is still starting the journey. If they're in the UK or they're planning to come to the UK, I would suggest to start the FRCOphth. Do not bother doing the other exams, because yes, they will be okay on your CV, but not enough to achieve what you want in the UK. Okay, that's one difference. Obviously, the other difference is the structure of the exams. Again, the number of exams. So, as you might know, everything is mentioned on the website. I'm not going to repeat what's mentioned on the website, but basically, the FRCOphth is 4 exams. FRCS is 3. Again, the FRCS Edinburgh is it's 3. The Edinburgh has been stopped for some time. Registration in the GMC has changed. I'm sure everyone knows that in the past the FRCOphth did not give you any GMC registration, but now it is. So that's quite a good advantage now, and they're trying to encourage people to enter the FRCOphth exams. The other difference is obviously is the pricing. The FRCOphth might be cheaper to sit in the UK. Outside the UK, obviously, it's much more expensive. So again, it depends where you live. So if you live in the UK, it just makes sense to chase up the FRCOphth exams. If you're outside the UK, in the Middle East or the Far East or whatever, then it might be worth doing the other exams. It's just personal preference, basically. Obviously, if you've already started your journey and then you've got only one exam to do, maybe in the Glasgow pathway or something, then do it, obviously. Because it's a shame that you need the qualification. And as you can see, that so I'm now focusing on the oral exam. Okay, I can support people with the basic exams, but I cannot give my time to everything. So I just prefer to focus on my bit, but I'm more than happy to support in any other way. I don't mind. I can guide you to sources of learning. If there's any courses out there, you can do that sort of thing. So the general idea is that the exam is the oral exam, the final exam is divided into Viva and OSCE, and then as you can see, lots of stations in the Viva, lots of stations in the OSCE, quite different than the Glasgow and the Edinburgh. So as you can see, the FRCOphth is focused on your practice in the UK. So you've got a much better chance of passing the final exam if you're practicing in the UK. Not because people outside the UK are not as good as ophthalmologists, but just the guidance, the protocols, lots of different aspects how we deal with patients here in the UK than elsewhere. So that is one thing, again, you need to consider, that the stations themselves. So let's say something like attitudes, ethics, and responsibilities. Like a very common question that recently came up. A doctor came in smelling of alcohol. What would you do in clinic? There is a specific way to do it. So someone outside the UK might sort of consider it as an easy question, but actually there is a specific way to escalate these things, and that's what it's written in the answer sheet. And if you do not follow that escalation, you're marked down. So So it's those sort of things that you cannot imagine that it would be a question that shows up in an ophthalmology exit exam, but it is what we focus on in the FRCOphth here in the UK. Another example is again audit, research, evidence-based medicine. There is a specific station for it in the Viva, as you can see in the FRCOphth, but it's not present in the other exams. However, they will incorporate a question. They can ask you whatever they want. So let's say in the FRCS Glasgow, they can get you a glaucoma patient and then ask you what's the recent trial that you're aware of. Have you heard of the Eagle trial? Have you heard of the Light trial? So they can sort of ask you the similar sort of knowledge incorporated inside the question. But it's not a specific station on its own, if that makes sense, okay? Otherwise, the clinical bit is exactly the same. So Viva, a case, you discuss the management, OSCE cases, again, it's a bit different between each exam, whether it's a patient or a video or just pictures, so it's a bit different. But now after COVID, obviously everyone was, there was no patients, but now they're moving it more to the hybrid sort of thing, and they're trying to get more patients. It's always nicer to have patients in the exams. I was a bit lucky because during COVID, when I had my exam, we had no patients. So we got assessed locally by one of our examiners in the hospital, and they just tested how we examine patients, and that's it. And then we went to the exam. It were all videos. So one might argue that is a good thing. Others might say, it's not good. It depends. But now, just you have to go into these exams having the mindset that you'd expect anything. You can have one patient, 2 videos. You can have 3 videos. You can have 3 patients. Anything can show up, and you always have to be flexible. That would be my advice in these exams, and always just know what you're going into. So you have to read about the exam. There's lots of guides. So the UK is all about guidance and files. So they've got on each of the websites lots of data about the exam, how it's structured, sources of learning, curriculums, everything is there. But again, it's obviously personal preference on what to do, what to read, those sort of things. Another very, very important station in the FRCOphth is the communication skills, which is not in the other exams, which is quite tricky. So it doesn't matter if you're, the best clinician out there or the best surgeon out there. If you cannot communicate with the patient, you lose that station. Okay, so and again, it's got a specific way to do it. Depends on the exact case, but they do assess you on how to communicate with the patient, how to sort of break bad news, how to explain things without a medical sort of jargon, that sort of thing. So again, it's not obvious it's not present in the other exams, but it's one of the, unfortunately, the tricky stations that if you struggle with, you might fail the whole exam because of it. And there is always this sort of bias for people who are the English is their first language, so obviously it's quite easy for them to go through that station without any hassle. If there is this language barrier, it becomes a bit more tricky. So again, you always have to bear that in mind. And I'm not saying that you need to take some more English courses, but you need to practice. All these exams, just practice and practice. And those of you who've opened the website, my website, and then went to the reviews bit, all of the previous candidates, their main advice was practice. You have to practice, okay? It's an act. So the whole exam is an act. And if you convince the examiner that you know what you're doing, you will pass very easily, okay? Okay, let's move on. I don't think... This is the marking sheet. Again, it's an example of what we do as examiners in the exam, how we assess you. So on the left one, that's the Viva station. And as you can see, so each Viva is split into 4 sections. So let's say 4 questions, okay? And 4 questions, each has got 3 marking points. So obviously 3 is the best, you know everything, you're perfect. And then as you go along, it's the same. the general idea is that as examiners, we avoid giving people 0 marks. We avoid giving people 3 marks, because 3 marks means that you're, your top end, everything, you've mentioned every single word in the answer sheet. You might get 3s, obviously. Lots of people get 3s in the marking sheets. But if what you aim for is 2, basically. So if you get 2 in most stations, you will pass. Okay, on most questions, you will pass. And as you can see, there is, other than the actual marks, there is at the top, there is a clear fail, borderline, clear pass, and then there is a feedback that you write down, fee text. So obviously, if I give you 3 in most of the stations, but then I still give you a fail, then the fail is the sort of the general idea from the whole station. Yeah. Obviously, the assessors, again, they look at the marks and then they look at the general pass or fail that you've put in. If there's big discrepancy, they will question you and then make sure that you actually put the right mark in. And they also compare between 2 examiners. So usually you've got 2 examiners. Sometimes you don't. If you don't, usually they record it, again, in case you appeal at the end or something. But usually both examiners at the end of the station, they should compare their marks. And if there's a big difference, they sit down together and then they kind of find a midway between both. And then so that's the Viva. Okay. There is a red flag. It's not obvious in this thing, but there is what we call a red flag. So a red flag means that you've been rude to the patient. You maybe hit the patient's nose with a sit lamp, which happens, especially if the patient's got a huge nose, and it happens in clinical practice as well, doesn't it? So you need to apologize if it happens. Don't freak out. You need to apologize to the patient and avoid being rude to the patient. That's the most important thing, because if the patient complains to the examiners, you might actually fail the whole exam because of this. Some others argue that a red flag would be missing a very, very important diagnosis, like endophthalmitis or GCA or a bacterial corneal ulcer. If you misdiagnose endophthalmitis, that doesn't show well at all. Even if you get the diagnosis incorrectly and then you answer the diagnosis later, once they prompt you, you just put yourself in the examiner's, shoes. How would you trust that doctor? Basically, if they are going to see your patient, let's say their colleague, and they will see your patient, if they miss an endophthalmitis case, you have to put a question mark. Yeah. So again, just a general rule: avoid red flags as much as you can. On the right side, that's the OSCE. Actually, that's the Viva. No, that's the OSCE. Yeah, on the right, that's the OSCE. It's similar. So usually 3 patients, and each patient has got 2 sort of parts of the question. The first part is the examination, how we actually examine the extraocular muscles, and then the next question would be the diagnosis and the management, differentials, those sort of things, and then they mark you for it. You have to bear in mind, again, if you fail one station, we don't care that much if you do well in the other stations, because it's a pass mark. So they calculate the whole mark, and then it depends on your cohort of candidates, your colleagues. We set a pass mark, and obviously it's a very complicated algorithm that they use, and then they set the pass mark, and that's it. I know candidates who failed by 2 marks, which is extremely annoying. And in that case, it might be worth appealing. You'd pay lots of money, and then they might look into it again. But usually, as far as I know, my experience, appeals are not that useful, I have to say. So again, bear that in mind. And again, sometimes if you fail the, let's say the OSCE bit, borderline, and then you've done very well in the Viva, again, that can compensate, okay? But if you fail significantly in one, no matter what you do, you cannot pass. What else I wanted to say in this bit? Fine, let's jump. Sources of studying. It's the same. I think it's the same for all exams. Okay. Lots of people outside the UK have been studying from the American Academy, which is great. I've read the American Academy. It's great. It's a great source, but it is different than the UK. Okay. So I would suggest if you are planning to sit UK exams, try and read, UK based textbooks. I love that book. So that blue one, I call it the blue book. Okay. Um, it's a bit outdated. It's not that new, but it's still very relevant because it's again very structured towards the FRCOphth exam, and it's got lots of very relevant stations, and it's to the point. It's not huge. It just tells you what you need to say, how you structure the answer. I think it's great. Bearing that in mind, you have to be careful that if you're reading a specific topic, let's say AMD, you will find lots of studies there, but there are new studies coming up. So you always have to be updated because that is something they really look into. They really love a consultant who is updated and knows the new studies and so on. So see, that would be my comment that, if we'll go through that later, but as you go along the book, you will find, a line saying, refer to this guideline or refer to this trial. Just make sure that this guideline is actually up to date, okay? Because that might cause problems. The one on the right, that's a Chua book, okay? Chua. I'm sure everyone has heard of Chua, but again, it's a bit old. The good thing about it is that it's got a section at the beginning about examination techniques. And I've done at some point in the past a session on how to examine patients, how to use the slit lamp, how to do the illumination techniques, because they might ask you, show me how you do a sclerotic scatter, which is something that we never do in clinic. So it might be worth going through that first bit of the book. It will tell you a bit more about the examination skills and what you need to bring in the exam and how to use the red pins and the head pins and those sort of things. And we might go through the examination techniques later. That I don't mind. That's fine. Just give me a sec. Fine. By the way, I cannot see the chat. Okay, so because it's not open in front of me. So if someone has got comments, I'd rather you say it out loud. Okay. No, so Ali was saying that one of the senior examiners told a group of candidates that the college operates the red flag only in relation to the UK trainees where they need to send it. Yes, so when it's a UK trainee, when it's red flag, they send it to the educational supervisor, warning them that your trainee has done this fatal mistake. Yeah, so please teach them better, or mention it in their next appraisal or whatever. Obviously, outside the UK, we don't have education supervisors, so but you are still red flagged, and a red flag might mean that you can fail the whole exam. Okay, fine. What else I wanted to say about this bit? Yeah, so again, Oxford Handbook is great. Kansky is magnificent. This book is additional. It's not necessary, but again, it's got very relevant stuff. I think, again, I always advise that with those practical exams, it's not about reading the whole book front to back. It's about practicing the clinical. So you need to practice either with your colleague or in a course that we've been doing the mock exams, just practicing, getting used to how to structure your answer. It's much, much more important than sitting on a chair, reading the whole book. It's not enough. That's not what they're looking for, because you've already been assessed in this, in the previous MCQ exams and your other exams. It's about how to actually apply what you've learned. But that's fine. So those will be the sources, your main sources to go back to. So let's say that you're discussing a case, either again with your colleague or in a mock exam or whatever, and then you want to refer back to the case, to the theoretical bit. Then you open the book and give it a read. But I wouldn't suggest, just relying on reading. It's not enough. Okay, very important piece of advice. Again, lots of textbooks out there about trials. I think RevEyes is actually with us in this group. I'm not sure if he's with us now, but his book is quite good. I've used his book for my exam, although my exam was like 4 years ago or 3 years ago. So just make sure that these trials are up to date. Okay, so just find the most up to date source and read it. Unfortunately, some examiners are a bit annoying when they ask about trials, because they might go into detail. So in the last Cairo exam, the FRCOphth, they went into the CAT trial for the AMD and the Ivan trial and details. So tell me, the arms of the trial. Tell me the results. They went into much detail, which I think is not fair at all. We're not assessing how much you memorize from the trial. Maybe you can remember, if you remember the name of the trial, that'd be great. If you remember the sort of the comparison in the trial, so we compared ranibizumab to bevacizumab, and then it showed that this is not inferior to this. That's enough. I don't need anything else from you. It's not fair if you go into detail in the trial. So my take-home message is, if you want to study trials, I would suggest focusing on the name, maybe the purpose of the trial, and then the conclusion or the outcome. If they ask you about more details in the trial, you will lose marks, but not all the marks. Okay, so it would be sort of a tiny question within the whole station. You might just sacrifice this mark. Okay, who cares? Obviously, if it is your subspecialty and you are well aware of these trials, great. But if not, then it's not a massive deal, because remember, it will be the case for everyone. Everyone will struggle. Because it's the same for everyone. So no one will spend all their time memorizing all the trials. It's not going to happen. But at least just focus on the main ones, the most up-to-date ones, and then go ahead. As I've said, in the FRCOphth, there's a specific station for it, like the evidence-based medicine one. In the Glasgow and Edinburgh, they might ask you in the middle, inside the question, have you heard of this trial? Talk me about this trial, or have you heard of these trials before? Or voluntarily, you can mention it in your answer. So managing angle closure glaucoma patients, and then you can just say, according to the Eagle trial, I think we can offer the patient this. So it just shows that you're aware of the trial and you know what you're doing, rather than just spitting what you've read in the book, in the textbook, and then it will show out. Okay, you will shine if you do that. It will differ definitely. Guidelines. There's 3 sources of guidelines, and this goes for all exams. So the NICE guidelines are the master that we follow here in the UK. Any clinical treatment that we offer patients, usually it's evidence-based with trials, and then it's put into the guidelines of NICE. Obviously, you do not need to remember the sort of the code for the guideline, but always memorize the important ones: so glaucoma, AMD, diabetic macular edema. Those sort of guidelines are quite important. So the very, very simple example is treating diabetic macular edema patients in the UK. You're not allowed to inject them if the thickness is less than 400. So, which is nonsense. If people are practicing outside the UK, they always inject everyone. So that's the difference. So if they give you, and they know that, so the examiners actually, they might be practicing outside the UK, they might be practicing in the UK, they know that difference. So if the question clearly shows that you've got a thickness of OCT, they've given you that thickness, so you can tell them that according to the UK guidelines, I will offer them this because the thickness is more than 400. So that would be how to structure your answer. Someone else might not be aware of the guidance at all because they've never practiced in the UK, and they're great ophthalmologists in their country. That's fine, but it's a UK exam, so they would expect you to know their standards. Okay. The other source of guidance is obviously the Royal College, which is a great source. Got lots of guidance there. So if you open the website, and then you at the top there's standards and guidance. I think there might be there like 80 guidance documents or something. Obviously, you don't need to memorize all of them, but the important ones. So let's say RVO guidelines, crucial, very important, and those would be updated. So with each file, there is the whole guideline, which could be like up to 100 pages. I think the diabetic one is like more than 100. But then there's the executive summary. There's another file, usually a smaller one, a summary. That would be the one to go to. Okay, short bullet points, just gives you the whole thing. Those would be the ones to focus on. So vein occlusions, AMD, diabetic guidelines, glaucoma guidelines, those sort of things. ROP. Again, some other less relevant stuff. So let's say how to do an intravitreal injection. There is a guideline to it, okay, and there is protocols how to set up an intravitreal injection, who does the injection, what's the room setting like, those sort of things. Something that you might have no clue about if you practice outside the UK, but at least if you read it very quickly, at least you know in the back of your mind that there's a guideline out there. Yeah, so if they ask you, have you read the guideline? Then the first thing you say is, yes, I've definitely heard the guideline. I've read the guideline. And then they will ask you, it's kind of basic. So you can come up with the answers, because you might say, oh, it has to be a trained person who does the injections, has to be a clean room, has to be very sterilized. We have to anesthetize the patient. You have to consent them first. Pretty basic stuff. So you can get away of actually, not properly reading the guideline. But never, that would be my suggestion, never say that I have no clue what this guideline is, okay? Because you would lose the mark. So tell them, yes, I've heard about it, or I've read about it, confidently. And if they believe you, they will start asking you questions and then try and, answer to the remit of your knowledge, but avoid making stuff up, because they will look at you like this and then they will know that you're making things up and they don't like this at all. So be honest, but not too honest, if that makes sense. Okay. The third source would be the GMC. That is a good medical practice document there. Again, pretty basic stuff. You think that, how would they ask me this in the exam? They would. So they would in maybe the attitude station in the FRCOphth, or the ethics, or even the communication skills. How to do consent, how to be kind to the patient, duty of candor, those sort of things. Again, we never use them outside the UK, but in the UK they're quite important. It hasn't got a specific station for it in the FRCS, which is great, but still relevant. Yeah. So if they discuss a case with you and then they tell you this patient has got dementia and you need to inject them or something, what would you do? So they can come up with this question in the FRCS still, but it's not a huge question. It's not a separate station of its own. The downside, obviously, of the FRCS as well is that it's got its medicine part of it. So there's a acute medicine station, general medicine station, which I hate, because we as ophthalmologists, we suck at read medicine. So it needs a proper sort of preparation to it. And I really like the cakewalk. I'm sure lots of people have heard of it. Cakewalk in ophthalmology. That's very, very targeted to the FRCS exam. Or Wong. There's another book, Wong. These two are quite good, but Cakewalk is really structured to the FRCS, and it's got a separate chapter at the end, general medicine. I don't think you need to study more than that, but it's a bit outdated. So again, be careful of that. Maybe you might need to refer to another textbook like the Oxford Handbook of Acute Medicine or something. Stuff like, how to manage anaphylaxis. A patient came in doing an FFA and then they collapsed. a patient you're doing PRP on, and then they fainted on the clamp, those sort of things. And then to differential diagnose, pulmonary edema, cardiac arrest, anaphylaxis, shock, stroke, those sort of things. The good thing about the FRCOphth is that it's not medicine sort of focused, yeah. Although they might sneak in a medical sort of question, like for example, guidelines about TIA. There's guidelines to it, the ABCD scoring, how would you refer the patient, how urgent would you refer. Very, very minimal medicine in the FRCOphth, but definitely in the FRCS, they focus on it. So be mindful of that.
Hi.
Yes. Hi. Who's that?
This is Romana.
Hi. Hi, Romana.
Hi. Could you please write down or repeat the names of the books for the medicine for FRCS
Oh,
class?
yes. So Cakewalk. Cakewalk. I'm sure lots of people have heard of it. Cakewalk was quite, popular. But as I said, it's a bit at least that's the version I've got. It's a bit outdated, so just be mindful, especially I haven't gone through the ophthalmology bit, but my focus was because in the recent FRCS course I was sort of reading through it because my info on this sort of station is quite low, so I was reading from the book, and it was noted that it's a bit outdated. So maybe the medicines have changed, the guidelines have changed a bit. So again, just be mindful of that. And on the website of FRCS Glasgow or Edinburgh, they ask you to open the Oxford Handbook of Acute Medicine. It's huge, but it would be good to just pick out the important topics, okay? And that would be definitely up to date. So if you think it was a bit outdated, just go to the Acute Medicine Handbook and read through it. But do not go into much detail. Just try and be as ophthalmology oriented as possible. It would be a case sort of scenario, and then, as I've said, they will ask you something medical, and that's it.
Thank you.
Yeah. Does anyone have any questions before I carry on till this point, or should I just move on? Okay, I'll move on. Fine. Okay, so next I'll give you some advice. A list of do's and list of don'ts, okay? And this goes for every exam. Hi, who's that?
Hi, I'm Dr. Sneha.
Hi,
I'm from
Sneha.
India.
Hi.
I'm an overseas candidate. So, Mustafa, if you do think if you attend this refreshing certificate and part 2 FRC of the oral exam in UK, we have got higher.
Sorry, your line has cut off a bit. So
straight, those exams in our home. Okay, can you hear me?
Yes, I can hear you now. So after the FRCOphth and part 2, yeah, the refraction and the part 2, yes. So what was your next sort of thing you mentioned?
Yeah, I was asking, is the pass rate high if we do the same exams in UK than if we attend the same exam in our home country, that is India, or overseas any other country? Do you think, is there any difference in pass rate?
If you, again, the beauty about these exams is that there's exam reports. Yeah, so whoever has got the time, you can download the reports and then compare the pass rates, okay? I think it's not fair. First of all, it's not fair to compare an exam in the UK to an exam in India, yeah? They just do it for the honesty and transparency of the thing, yeah? But from the candidate point of view, how would you compare a pass rate of 120 candidates to just 20 candidates, yeah? So I don't think it's fair to compare. That's one. Second of all, as I've said before, the most candidates sitting outside the UK are actually Indian or Pakistani or Egyptian or whatever. Their chance of success is a bit less for the reasons I mentioned before. It's not because always people they blame the examiners. Oh, they Pakistani exams, they're very tricky. My colleague sat in India last year and they struggled. It's not about the examiner or about the exam itself. It's about how our mindset is and how we're trained, basically. So if you prepared well to the exam and you've spoken with previous candidates and you know what you're getting yourself into, you should pass, because it's the same questions. The examiners cannot go outside the remit of the questions. So the Viva questions, they're already written. Yeah, so they're already, we come up with the questions. So in the recent sort of workshop we've done like 2 months ago, it was a huge table, and then all the examiners were sitting down, and then we started making up questions. And then it was sort of reviewed by the examiner committee and the senior examiner, and then once it was approved, it's put on the MCQ bank. So it's structured. It's already written down. It's not like we make it up on the day. Yeah. For the OSCE, however, that put in mind for the OSCE, we actually make up the questions on the day. But usually they're very, standard. Like, a thyroid case, which comes in every exam. Thyroid case, diagnosis. How would you manage a thyroid case? How would you point out an optic neuropathy, compressive optic neuropathy? How would you manage this? Pretty basic questions. It's not very deep. Yeah. The only thing that would change, I have to say, is the attitude of the examiner. Yeah. So that is something that you cannot control, unfortunately. So some examiners are very tricky. Some examiners are very chilled. They don't care. They're very nice, and they're quite, they help you out. Yeah. So they try to point you into the right direction. Some other examiners actually go the other way. So they sometimes point you in the other direction. Whether it's intentional or not, I don't know. But that is something that the college assesses. So if you saw the feedback that they do, they actually look into this. There's assessors that come and they look at the examiners, they assess the examiners, and if they think that this examiner is not at the right standard, they cannot examine again. So it is assessed. It's not haphazard. It is a very structured exam. So I wouldn't. So to answer your question, I wouldn't let previous candidates' experience or the previous mark rate to put you down. I'd suggest if again, it depends on your personal circumstance. So if it's very expensive to come to the UK and sit the exam, or due to family circumstances you cannot come to the UK, just sit it in your own country. But it will be much more expensive. That's what I know. It would be sort of triple the price if you sit it in India or Egypt or whatever. So I'd suggest it might be worth just getting a visa, come to the UK, have a nice time, have a week off, enjoy London, sit the exam, and then go back. It will be cheaper, than sitting it actually overseas. So some people do that a lot. The reason why they make it more expensive because they actually reimburse the examiner. So if I go examine in Egypt, they pay for my flight, they pay for my for my hotel. That's why it's cheaper. So that's why it's more expensive outside the UK. But I wouldn't be put off from previous. So just avoid India, or avoid Malaysia. It's not like that. It doesn't look like that, because actually most of the examiners might actually come from the UK. Yeah. So any examiner can show up. It doesn't necessarily have to be the same examiners that show up in every exam. You could have any examiner from anywhere. Okay.
Okay, thank you so much.
Yeah.
Thank you.
There's other hands. Who's that? RK. Who's
Hello.
that? Hi.
I'm Rashida here.
Hi.
Thank you, Mustafa, for this talk. It's very informative. May I ask you, when I was reading through the details about your RevEyes course, what is the difference between the weekend course and the mock tests? That there was an option of just having a video of 20 mock tests. What is the difference between the two?
Yeah. So I'm sorry if it wasn't that clear, but the mock exams are recorded. Yeah. So those are the ones that we've done before. Only 5 exams. Yeah. So the reason I put it there, because some people, they just cannot be bothered attending a course every week, because I'll go through the course in a bit. But my suggestion is, if you are signing up for the course, you have to know that it's weekly, hopefully it's going to be weekly. We'll try and make it every weekend probably. But that's the advantage of the course, is actually to go into the course and participate, because that's the benefit. You have to practice, and it's timed. I'll go through a bit more on the course, but that's the benefit of it. So if you're not planning to attend at least every week, obviously if you miss one or two, that's fine. It will be recorded. I can send it to you. That's fine. But you're paying money to participate, to be assessed. That would be to practice talking. Some people do not have the time, or they cannot, they work on weekends or whatever. Everyone has got his own circumstance, or the time different, because lots of people are joining us from Malaysia and Far East. They cannot attend in the right time, so they cannot participate. So that might be an option for them, is just to watch the pre-recorded videos. The 5 exams that we've done, I'm pretty certain that most of the exam stations haven't come out these topics, because these are the most important topics. But obviously, it's recorded, so you don't have the option of giving the feedback to the candidate and having that discussion. That's the beauty of other courses, that there is this discussion that generates from it. So that's the difference. So if you see on the website, there's an option of just 1 mock exam. You can try it out if you wish. Option of 5 mock exams, which are the ones that we've done, or there's the course. So there's either 8 exams, and that might be okay for people sitting the FRCS in March, or those sitting the FRCOphth in February or something. That might be okay for 8 weeks. Or for those sitting afterwards, like in April or after that, then it would be the 4 months, which is 16 mock exams. Or you can do both. It's up to you. I mean, it's very flexible.
If I understand correctly.
Yeah.
So the course, which is over 8 weeks, is going to be every weekend. Means it will be either Saturday or Sunday, or it will be on both the days.
No, so it will be either Saturday or Sunday, and that can be agreed, within the group. So obviously, once I'm done with this talk, I'm aiming to start next week. So I'll come up with a new group, a separate group for those enrolling in the exam and in the course, and then we will decide when to do the next session. And it's quite flexible. We can change it. That's fine. But it's either a Saturday or a Sunday. I think it would be too much to do a Saturday, Sunday straight after each other.
And it will be how many hours?
The exam roughly takes 4 hours, roughly. It should take 3 hours.
It will be 4 hours duration, either one of the
roughly. So from my previous experience, the previous mocks we've done, it should be 3 hours because it's timed. But obviously, between each case, there's discussions. Everyone has got a question. We sort of come up with other stuff in our minds. So it roughly stays for 4 hours. Again, as I've said, it's quite flexible. So we have to bear in mind that we'll have to go with the majority, unfortunately. So if the majority says we do it on this day, on that time, we'll go with it. And some people, as I've said, as yourself, from India. So there's a big time gap. So the previous ones we've done was actually at night on Saturdays. So that wouldn't work for you guys in the Far East. So we'll probably make it around this time, like 12 UK PM time, roughly. But again, as I said, that will change. That's not a big deal. Isra.
Thank you.
Isra has. Yes, okay.
Hello, thank you. So we went through the books. Thank you very much for that. But is there any, of course, apart from the NICE guidelines, Royal College guidelines, and the GMC guidelines, do you recommend any online resource? Because the books are most of the time, they can be out of dated, especially for the studies and everything. Is there a website which summarizes all the studies and everything like that?
As far as I know, so there is the iDocs website. It's got a source of, again, guidelines and studies, but it's extremely outdated. Yeah, so I wouldn't go with iDocs. I don't like iDocs, to be honest. I've enrolled in iDocs before. I've done their MCQs, but they're very outdated. And as you might know, the hassle that happened recently, it was shut. Everyone was freaking out. So it's not that, I would advise. I think if we go through the stations, the studies are actually well known. So the important ones, let's say the glaucoma or the AMD or whatever, these are quite known. And the good thing as well, so obviously, you know, I don't know everything in ophthalmology. You don't know everything in ophthalmology. The good thing about the group discussions is that most people are actually consultants. They're very senior and they are up to date, and everyone has got their own experience, and that's how we learn. Yeah. And then new ideas come up, new studies come up, and then we can search for them, and then we can go through it together. So do not worry about, you know, looking for the most up-to-date source. It's quite known, basically. Again, I've got a few sources of a list of trials, basically. That I don't mind, you know, posting it at the group. That's fine. Again, from other courses. So I'm sure you guys have heard of the London Eye course. You've heard about the Oxford course. There's lots of courses out there, and each usually have they offer the list of the most up-to-date or the important trials that we need. Yeah. But I'm sure that most of them you will already know. It's just actually knowing the details of them, so that the name and the conclusion and so on. So, but yeah, to answer your question, is there just one place that you can just access and then just have a list? It's not like that. Because again, someone mentioned before actually that why not, you know, let's come up with a book or something with the most up-to-date trials. The problem with trials is that it always changes. So there are new stuff coming up, so you cannot be always up to date with the new trials. The only way to do that is to actually attend conferences and read papers and be most up to date, you know, and then you know, that's the only way you can do it. Actually, it's not like theoretical exams where you sort of open a book, memorize them, and that's it. It's not like that. If that makes sense.
Thanks.
Fine. Karim has texted me. Okay. So Karim is the Karim is the person who got the top score overseas, because I told him to come in and say a few words if he can. Fine, let me go, and then he can join whenever he's free. Okay, so some advice. Obviously, you need to be prepared well, dress appropriately, not like a suit or something, but you know, semi-casual, or sorry, semi-formal. You need to get previous feedback, which is crucial, and that's how you learn from previous mistakes. What's common is common. Yeah, so I don't care if you spot, you know, the most rare retinal dystrophy, because actually I might know it. I might not know it because I might not be a retina specialist. Yeah, so the examiners, usually there's a specialist in that area, and then there's a non-specialist, just to keep things as fair as possible. So I don't care about the name of the dystrophy, but I do care if you're struggling using the indirect, for example, or if you miss an AMD, which is the most important thing. Yeah. You have to listen to the questions asked, especially in the something like the communication skills station. You're giving a specific task. Do not go off that task, because that will mark you down. So you need to be focused. And again, something like an OSCE, if they ask you to look just in the cornea, just comment on the cornea. Just be straight to the point and just listen to what they're asking of you. Again, this sort of structuring your answer, this just again comes with practice, and that's what we do in the course, that we try and get people to practice talking, because everyone knows the knowledge. You know, I'm sure at this stage everyone knows everything, or at least the most important things, but just how to formulate an answer, because we're not trained in answering questions as it should be in the exam. So you have to sort of quickly. It's not easy. It's a hard skill to attain. You need to take a few seconds, build up the answer in your brain, and then spit it out. And you need to be confident about it as well. Some people are great, you know, but they just keep sort of, you know, hesitating in their answer, repeating what they've said, or maybe changing what they said. So it just doesn't show that you're confident. It doesn't show that you've actually done this before a lot. So If you convince me that you've practiced, then you will pass. Yeah, confident, consistent, do not change your opinion. So do the extraocular muscles, and then I would suggest, discussing what you're doing as you go along, and then just saying it as you go. Yeah, do not wait until the end, because you will forget things. And then, sorry. And then be calm and nice to the patient. It just shows that you're easy. Yeah, you're not stressed. But do not be over nice. It shows that you're weird. But just, be eye contact with the patient. Be nice to the patient. Maybe throw in a small joke. Just make them feel at ease, because bless the patients. They're there for the whole day and every day. And imagine people shining their light into their eyes. It might be nice to, be nice and kind to them. When you get asked about technique, yes. So if you keep it personal, it actually shows that you've done this before, even if it's a lie. Yeah. So even if you've never held the direct ophthalmoscope before, you just tell them this is how you do it, for example. Or if they ask you about how to do a canthotomy cantolysis, I'm sure lots of people have never done it before. Yeah. But you should be confident enough to prove to the examiner that you know how to do it and you've actually done it before. So I would say, okay, this is the way I do it. I do this, I do this, I do this. Or you can say, according to our local protocols, we do it this way. Yeah, because it will change. Something like intravitreal injections, again, it changes between units, changes between countries as well. Be quick and efficient. I would suggest, again, if you get stuck in a question, maybe spend a few seconds thinking about it. But if you don't know the answer, just say, I don't know. Yeah, because otherwise you're losing time and you're losing marks. So the good examiner will lead you towards the next question if they think that you don't know the answer. But some examiners just, are sort of mask face. They don't care, and they just leave you to it, and that is not good. Okay, so at some point you'll have to decide, okay, that's enough for this question, let's jump to the next one. Okay, that's fine, you lose 1 mark maybe, but they want to give you more marks as they go along. Patient safety. If you are going to pass, they need to make sure that you are a safe consultant. It is a consultant level. Yeah, so you are a consultant, you're a junior consultant. But do not say that I will get help from my senior consultant. Do not do this. You can say my colleague. Yeah, that's fine. You are the consultant, so you are the boss. Yeah. So just say I will consult with the VR colleagues or the VR consultant. That's fine. But avoid saying that I would consult my senior, because there's no senior. Yeah, you are the senior. All right. Again, it's all about guidelines and protocols. As I said, these are the sources. Yeah, so the NICE guidelines, or the college if they're clinical, or if it's sort of ethical or attitudes or patient sort of management, communication skills or whatever, that would be the GMC. Again, there is always going to be a weird station, a weird question that you've never heard about. The key is not to panic. You need to take a moment and always only remember that it's the same for everyone. So most people will have the same sort of level of knowledge. Only a few will know the answer. Only a few will have no idea about what's going on. But in that sort of middle gray area, most people will lie there. And those who do not panic will be the ones who pass. But those who panic, they will fail. Okay? So always imagine that in that sort of spectrum. And again, remember that if they ask you the diagnosis and you get it incorrectly, you've lost 1 mark, maybe 2 marks. But there are other questions. So if they say, okay, let's imagine this is a third nerve palsy, what would you do in this case? Then you carry on and answer. If you answer it very well, they might pass you, even if you've got the first diagnosis incorrectly. Although that in mind, some diagnoses that you cannot misdiagnose, like a pupil involving third nerve, a painful Horner, like a carotid dissection, which again came up in the recent exam. You cannot miss those, because if you miss those, that's fatal. That's your patient dead. So some things in ophthalmology, very few cases you have to memorize quite well, okay? Because you cannot miss them. Okay, clinical trials, obviously, we've mentioned that. But again, do not to waste too much time on trials, okay? So I'd say, you know, as you go along, be aware of the important trials and maybe revise them again before the exam, but do not spend too much time revising the very rare, very old trial that you know about a specific topic. It's just a waste of time, I think. Practicing is very important. And it's very important that I need to mention that if you decide and enroll on the course, it's not enough, okay? So the course will sort of build up on the knowledge that you already know, which is fine. Knowledge is okay, but it's about the practice on patients. So you need to be very easy examining patients. So you need to be very confident using the direct, which no one uses. But in the exam, if you sort of start fiddling with the thing and then, you know, not knowing where the knobs are, that's a fail, yeah? So you need to practice, and obviously we cannot do this in the course. So in your own time, with your own patients, you need to practice a lot, like extraocular muscles, cover testing, you know, using the Hertels, exophthalmometer, those things that we never do on a daily basis. And the examiners know this. So the fact that you actually can do it on the exam, that just means that you care enough and that you've practiced and prepared well for the exam. And that will give you marks. So just about confidence. And again, I would suggest avoiding doing the same maneuver again and again. So let's say if you're checking the field, so you do this and then the patient stops, avoid going to the same thing again, because that just shows hesitancy. So just do it slowly, done, next quadrant, done, other quadrant, that sort of thing. So just take your time and do it in one go if you can. You do have the option of repeating it, but again, that's just losing time. Like one of the candidates, again, she was looking at a video, again, extraocular muscles, and then she was writing down stuff. So that was a bit odd. I think she wasted time. Although I think she passed. I think I've passed her, but she just wasted lots of time. So it gave me an impression that she wasn't confident, and she just lost time. So avoid writing things. I think that's useless. That would be my personal opinion. Yes, so again, you need to be general, you need to be broad-minded. Do not go into much depth into the topic. Remember, you've got a better success chance if you are actually more junior. So it's very, very difficult if you're more senior, because you're very into the specialty and you've got your own way of doing things, which could be great. But it might not be the way we do it in the UK, or it might not be the way that consultant does it. Yeah. So try and be as general as you can. So let's say if you're a VR surgeon and you do not do any buckles, yeah, you've never done a buckle in your life and you're a very VT pro person. In a specific case, if they mention this case, what would you do for this particular case? Just say a buckle. Okay. So just change what you do. Do not go into that argument with the consultant, okay, with the examiner, because it wouldn't end well, okay? They will give you the respect that you know what you're doing, but it goes against what the standard practice is in the UK. So it's a small example, but you know, have that in your mind. So just try and think as a general newly appointed consultant as much as you can. Avoid going into detail about that particular specialty, especially if you're a consultant in that particular specialty. It just gets very tricky, very hard to do it. And that's the question that you need to ask yourself, basically, if can I actually trust this person to join me and manage my patients or not? List of don'ts. So avoid red flags, being rude. I know someone who hit the patient's nose before and they failed. Missing a blinding disease. GCA, obviously. GCA, we never see it overseas, but it's very common in the UK. avoid wasting too much time looking for okay, you might do the hand gel thing. It's fine, but who cares? At the end of the day, they're not going to mention it in the marking sheet. Being too nice to the patient, which feels a bit odd and weird. So again, avoid that. Arguing with examiners, that's a big no. Okay. Avoid saying anything stupid. Yeah. So stupid means odd. Yeah. So they just will think that, what the hell are you saying? Yeah. And that will just mark you down, no matter what you say afterwards. As they say, always, the first impression lasts forever. So if you step into the station and then, let's say I'll ask you to do, a cover test or something, and then you end up doing something else totally. So it's a weird sort of thing that you've done. Or I've asked you a question and then you answer a totally different thing, which happens in the stress of the exam. That's fine. But it just shows that you're really stressed and you will lose marks from it. So try and avoid saying anything odd or doing anything odd, okay? And remember, it's an act. So if you act well, you will pass, okay? Again, avoid making things up. We've mentioned that before. Panicking in the comms skill station, most importantly, and they might get you a very, very tricky patient. And they're actors, professional actors. They might shout at you. They might insult you. They won't insult you, but they might make you feel very, very, very bad and stressed. So that would be something to avoid if you can. Hang on a sec. Soon. Fine. Fine. And don't be alarmed if you do unwell in one station, just fine, because remember that there are also stations. So there will be a sort of a leeway. And if you do well in one sort of, if you do very well in the OSCE and you fail slightly in the Viva, they can pass you still. Okay. Let me talk a bit through the course itself. Has anyone got any questions at this point? No questions. That's great. Fine. I'll talk a bit through the course. You'll all be. Is Kareem with us? I don't think he's Kareem.
Sorry, Mustafa, can I quickly ask, please?
Yes.
I joined late, unfortunately. I wasn't sure if you covered it. I can always go back and listen to the recording, but at the start, did you cover how many stations there were? And you did? Okay.
More or less. So you're talking about the FRCOphth, aren't you?
Yeah, don't worry about going through it again. I can listen to the recording. I just wanted, because I joined a little later. I assumed
that's fine. We've got time. It says basically, as you can see, there are 5 in the Viva and 6 in the OSCE. And then with each station, either if it's the OSCE, it's 3 cases, whether it's 2 patients or one video or the vice versa. In total, like in the course, it'll be 21 stations or 22, 20, something like that. 20. I think it's 20. So that's the total number. It's similar in the Glasgow and Edinburgh, but as I said, for each person who is following this sort of pathway, they can read more about the exam on the website. It's quite obvious, but it's similar in the structure. But to answer your questions, it's roughly about 20 cases.
Perfect. Thank you, Mustafa. Sorry about
that. Okay. That's okay. I think Kareem should be joining now. Okay, so Kareem has joined us now. Kareem, can you hear me?
Hello. Hi, everyone.
You okay?
Very nice joining you after
So I know that you're busy, and so I'm sure everyone has read my message. So Kareem, I'm very proud of him. He's a friend, Egyptian friend, and he passed the Cairo exam recently, and he's ranked the top scorer in 23 overseas. And he's quite good. I've spoken with him a lot, and I just wanted to ask him advice. So if you give people advice sitting the exam, so some people have unfortunately failed the exam once or even twice, sometimes 3 times. Yeah. Some people have, failed it once. Some people have just joined the whole thing and they are starting to prepare. So what would be your advice? So what would you say to that question?
Well, first of all, I'd like to tell everyone, you might think that the exam went smooth for me, but it's completely opposite. Like, it wasn't smooth. I didn't have a smooth exam. I didn't do good in all the stations, just like a normal, like everyone had. I had difficult stations, a couple of ones. I didn't know if I passed the station or not. But in the end, in the overall, I was able to perform on the easy ones. So like the overall score was good. So during the exam, my advice for everyone is like, don't panic. Take it station by station. Whichever station you find difficult, it's okay. It's on everyone. Just try to, as soon as you move out of the room, forget it. Like, move on, go to the second station.
But it's not easy, is it? It's not easy at all.
It's not easy, but if you were able to do this, you will find the exam very much doable, because when you miss a difficult station, it's okay. But if you made like an easy station and you screwed it up, then you are in a big trouble, because most of the other candidates will do it well. So then you are below them and you have to catch up in a difficult one.
Exactly.
So keeping the pace with other ones is just doing the basic, which is doing good in the easy stations. And the exam is testing both, like, 2 things for my like own experience. The first thing is they're testing emergencies. So you'll have emergency cases. Like we had in our exam a carotid artery dissection case, another endophthalmitis case. So they'll have to test you on emergency cases. These cases, they would just, to pass the spot, you'll have to know that you'll manage it urgently, know how the sequence of the events have to go. These spots are important, just not to screw it up in a way that you just discharge the patient. But you won't have to like get the full mark in this station. Endophthalmitis case is very easy, but a carotid artery dissection wasn't that easy for other circumstances. Examiners, you will find like good examiners, you will find pushy examiners. Just completely ignore it. Try to go with the flow.
Something you cannot control, unfortunately. It will happen. It will happen, yeah.
It will happen. You cannot avoid it. But if it happens, just in the end of the exam, during the review, just mention it. And surprisingly, you'll find that every candidate will have the same comment in the same station. So this is a positive thing, because they take this into account. And
yes, that's what I've said yesterday. So for everyone, again, because for some reason, we always have this sort of defenseless position. So I cannot speak. I'm afraid to speak. I'm afraid to talk, to someone. You need to speak because that's your right. So that's why the assessor is there. That's why the examiners are monitored. They hear your feedback. They take it into account. If it's not this time, it'll be for the next time. So it always, and nothing is perfect. They always try to improve things. And importantly, so like for instance, in Dundee, the indirect ophthalmoscope was a very, very old model, and they were struggling to put it on their faces because he had to sort of click it on to make it turn on. And people who were, ladies with hijab, it couldn't fit in. So they struggled and they lost time and they panicked. So that is something that everyone has commented on, and they put that into consideration. Okay, so they gave them a bit more time in that station. So that is something you need to say. So if you do not say it, if you do not document it by mouth or by writing, it didn't happen. So you need to mention it on the day. Do not be afraid to speak. Yeah.
Exactly. Another thing is like during the exam, just try to keep confident throughout the exam. Examiners are with you. I was told before the exam that it would be a miracle if you got a 3 in a spot. No, they give you 3. Like I took a couple of 3s in most of the spots. So the examiners, they are trying to give you points. They're not trying to take points from you at all. As soon as you mention the keyword, you get the mark. So some examiners are a little bit greedy in their marks, but these are very small number of examiners. You don't find them a lot. Most of the examiners will give you mark. So just try to act as if you're in the clinic. You have a normal case, manage the case normally, and you will get the marks that you need. And always think common. Do not think uncommon. Most of the exam will come in the common things because they're just testing your common practice. So expect something common. Don't try to think out of the box too much. It's not very common to get things that are rare.
Yes. So again, remember that, you know, if they, let's say they struggle on the day to find patients. Yeah. So let's say a neuro station, they can't, which happened in Greece recently. They couldn't find any neuro station. They had to bring videos. Does that mean that they will get you the most rare neuro-ophthalmic case? It's not going to happen. Okay.
Exactly.
So they will get the common stuff like the palsies, the nystagmus every now and then, the field defects, very common, the RAPD, the common stuff.
Exactly.
And even in your sort of way of answering, you have to be structured. So either answer it in a surgical sieve way, or you'd say this is the most common likely diagnosis. Other differentials would be 1, 2, 3, 4. Just start with the most important one, the most common one, and then say the less relevant stuff at the end, which will be mentioned in the answer sheet. Yeah. So you will not miss a point if you forget one of those, but you will miss lots of points if you forget the first one. That would be the take-home message. Yeah.
Also, before the exam, try to prepare yourself to like get a structured answer, because we all study, we all have the information, but we don't all express our knowledge structurally, because we have to have a structured answer. And this impresses a lot the examiners when you start with a structured exam, giving him the life-threatening, side-threatening, then the most common. This will help a lot him like evaluate you and look up that you are practicing in a good way. This won't come by studying from the books. This will come mainly by trying to talk out your thoughts, because when you start to express thoughts, you will say things screwed up. You won't always get it right. You will have flight of ideas. You will say something from the beginning, then you will go to the treatment, then you will forget something from the investigation, so you will go back to the investigation. So this will make you look like messy in the exam. So I'd rather have this during the preparation period. This you can do a lot in the course with Mustafa. It helped me a lot in the beginning, helped me in the structuring the answer, like knowing the form of the exam. This helped me a lot, really. 3 months before the exam, I didn't have the course yet with Mustafa as well. I was studying, just sticking with Oxford, Blue Book, having a read of it, and it was, I found it not enough because I was not prepared. Then afterwards, I knew how the exam is going to go, attending a couple of mock exams. Then afterwards, I studied with the friends. Our way of studying different because we started practicing mainly by conversation. Like each and everyone has to explain a disease in his own way. Then they will just adjust whatever I missed. So then you'll know how to structure the answer in the end of the preparation period. But in the beginning, it's totally normal. Throughout the study period, I had my ups phase, which I felt very well prepared for the exam. Then before the exam, by like 3 weeks, I had a down phase.
You forgot everything. I know this feeling.
I don't have anything. I forgot everything. I need to restart again. But this is completely normal. Don't panic. Then we had a mock exam. I did well, so I'm up again. Then before the exam, I had a down phase because a couple of questions I tried to answer, it wasn't structured. I wasn't happy with my performance. So don't panic. This is a like process. You have to trust your process. You put in the effort. You try to arrange your thoughts, and this will happen to everyone. You will have up and down phase. Just keep moving. Do not stop. Try to have, if you have any colleagues that can study with you, attend with the mock exams. Try practice. Try to talk. Don't be shy. You will screw up in the beginning, but this is totally okay till the day of the exam, which will help you a lot. Even in the exam, you might screw up a couple of spots, but try to stay calm, maintain your composure, and things will go well. Don't worry. The pass rate is around 70%. This is very much acceptable. So most of you will pass, hopefully.
Someone was asking about the trials and how would you answer to that? So how would you keep up to date with the most, the newest trials? Did you have a source to read from?
I studied the trials. I put in the effort in the glaucoma trials because from the feedback I had, previous like candidates told me that they ask a lot about the glaucoma trials. Then when I went to the day of my exam, we got asked about the CAT and event trial, which is the oldest trial in the AMD.
Yeah, so, it's not. I told them before you joined us. Yeah, it's not
exactly. Fair. I knew the title only. I didn't know anything else. I knew it compared bevacizumab from ranibizumab. I knew the results were the same, similar results, but exactly the specifics I did not know. But I totally ignored that because I knew that no one else would know this. Like this is so common. None of the candidates will know this at the answer. And as soon as I went out of the stations, when they came to ask us about the exam, like everyone burst up because of this spot. Everyone said, "Do not answer. This is the oldest study, and this is how you expect it." Do you think if I came back in time, I will study this again? No, I won't. I will not waste time. AMD has a lot of studies. I'll try to keep up with the updated. Try to know if anything is mentioned in the NICE guidelines. Then I just try to know them in titles, what do they compare, and that's it. This spot, I didn't do well in this one. The other side of the station was contact lens questions. It was okay. A couple of hard questions, but it was okay. In the end, we passed the spot, even borderline. I didn't do well. I got a 15 out of 24. So I didn't do well in this spot at all, but I passed. And this is what you want from a spot like this. Like this station, no one will get a very high mark in it. Even if someone did, it would be from the extreme. In the they usually have a bell-shaped curve. So if you get someone from the extreme, you don't worry about them because they will not change the curve. They will not change the average. Just
exactly. That's what I mentioned before. So imagine it's a line spectrum, and then the very hard questions, ignore them. The very easy questions, ignore them. The central questions, these are the ones that we call discriminative. Yeah. So they will discriminate between good candidates and bad candidates. Yeah. So they might be easy questions, but some people will stress out. Some people will make a silly mistake, and those will be the ones who fall down. Yeah.
Exactly.
And that's why you need to keep calm. The knowledge will be the same. Everyone will have the same level of knowledge. If you miss 1 or 2 points, that's fine. But as Karim was saying, once you exit the door of the room, just forget what happened and then focus on the next one, because that will just mark you down if you
I'll tell you a comment I had like after the exam, before the results even. We had the head of examination, the Dylan and I can't remember, Sophie, I think, were there. They were arranging the stations and who was in, holding the stopwatch and stuff like this. So I finished most of my stations early. Like I had maybe 3 minutes in each station to spare. So I went out. I used to I joke with Dylan, speak with Sophie. Like most of the candidates even told me, like, did you do well? I told them, I don't know, but I'm just trying to break the ice. I'm just trying to feel confident as if I'm in my hospital. I'm just going in the room, examining patients, going out. So as soon as I went out, I started talking to whoever is next to me. Just to, my mind won't think about the previous station. I talked that. Even he talked to me, asked me, if you passed, what will you do in the UK? Are you married or not? And we had like a discussion as if we're sitting somewhere in London. So it's nice sometimes to break the ice, like try to get yourself out. If you feel that you are worried or in stress, just try to talk. Sometimes it helps so that you don't think about the station. Also, a mistake I've done is in the OSCE exam, I started with the posterior segment. Like everyone else, going to the OSCE, I had in mind the neurospot and the orbit station and squint, just trying to focus to do well in this hard stations. So I had the posterior segment following by the orbit and squint, then the neuroophthalmology. And I did very well in these 3 stations. Then as soon as I finished the neuroophthalmology, I had the anterior segment. So I was like, okay, now I'm done. Anterior segment is going to be easy, hopefully. So I felt a little bit relaxed. Then I went to the anterior segment and I got shocked. I felt very confident. I felt that the exam ended. So I screwed up very easy cases in this station. Like microbial keratitis, the video was not very well. Diffuse light, you couldn't determine the region. Then we had a complicated cataract case in both eyes.
Very risky what you've done.
Straightforward cases you should answer. Then I struggled to structure. Like I answered in the end, but it was prompted a lot. And I lost marks that I shouldn't have lost. Just because I felt that anterior segment is doable, it's very easy. So let's get it done. Then I went to the glaucoma station, regrouped myself, and did well in the station as well. So don't feel that anything is easy. As soon as you feel that you've got this in hand, it will get lost. Keep your focus throughout the exam. You feel it's long, but it will pass. Just keep your composure and everything will go well. Just your posts.
Has anyone got any questions for Karim at all? Again, Karim is on the group, so I hope he doesn't mind if anyone wants to sort of text him at some point. Just try and text him 3 a.m. in the morning when he's asleep, please. Yeah, just try to bother him as much as fine. So if I think we'll move on. Thank you very much, Karim. Very appreciated. And thank you very much. We'll speak later.
Well, I thank you before in private. I'd also love to thank you in public.
That's okay.
Beautiful effort with us, and it's very much appreciated. You own my prize as well.
Yes, I'm still waiting for you to come to UK so I can just split it.
Yes, exactly. Thank you so much.
Cool.
Okay.
Thanks, Karim.
Good luck, everyone.
Fine. So let me quickly go through the course. So this is the website. Okay. So you'll find lots of info there. So there's the video, obviously. It's about 5 minutes, gives you a quick sort of overview of the course. Again, About has got some info there. Sample videos. So again, some stations, you know, after taking consent from the candidates, I'll put a sample there. And there is a few on the web, on the YouTube channel as well. Reviews, lots of, again, previous comments from previous candidates and those who passed. Again, a few advice there. FAQs, and then there's the courses. Okay, so as I've mentioned at the beginning of the video, there's 1 mock exam. There is 5 mock exams. These are the recorded ones. If you're not keen on committing to every week being there and participating, that's fine. You could always get the recorded ones and then watch them. They're very useful. Okay. And there's the 8 weeks and then the 16 weeks. The issue is that some of you are still waiting on the written results. Yeah, I'm not sure when those results will be out, but it might be in a week, it might be in 2 weeks. So you might, because my sort of original intention was to start the course actually next week on 16th, because if you do the math, if we're aiming for 16 exams, that will just barely put you before the April exam. Okay, so, and we will probably need to take 1 week break around Christmas and New Year. As I've said before, if I might, maybe today, I might put a voting poll on the WhatsApp group. It might be okay to wait a bit for another week and maybe start on the 23rd. 23rd, I think it's 23rd. Yeah, that's a Saturday after that in 2 weeks, rather than start next week. If those who are still waiting on the written exam would like to join us from the first exam, okay? Or if most people decide, let's start from next week, 16th, and then take 1 week off, either the one after that or the New Year's one. That is an option as well. And then for those who want to join us later, that's fine. It's going to be recorded anyway. So if you want to join midway in the course, that's totally fine. It's up to you. Some people have enrolled already, which is great. I will have to give priority to those who are sitting the April one, I'm afraid. So if you're sitting after that, I think it's too soon. Yeah, so I'd suggest you to wait either 2 months or 4 months before your exam, and then you can join. So I will try and limit the number, and I will try to just focus on those sitting the FRCOphth in April. Again, for those sitting the FRCS, just bear in mind that the mock exam, as I said, it will be stations and timed, and between each station we'll have this sort of discussion, and I'll give you feedback on your performance and so on. So it's not structured as the FRCS. It's quite similar. If you go through the stations, very similar, but we will go through the, as I said, the attitude station, the evidence-based medicine station, those sort of things, which are very relevant as well for the FRCS, but it wouldn't have a specific station for it. Okay. Some have sort of, asked me to do 2 separate courses. It's not easy. I cannot do an FRCS course and an FRCOphth course. It wouldn't be easy. Okay. If we really need to do it at the end, we might, but not now. I can't do both. It will be very hard work, because spending the time to do the exam and then the 4 hours of the actual mock exam as well, it's pretty hard work, as you might imagine. So we'll just focus on 1 exam, which is the FRCOphth, and then those sitting the FRCS can definitely join. You're more than welcome, and it will definitely benefit you. Okay, and please have a look at the YouTube videos. It will give you an idea of what we do, and that's the YouTube channel. I've got 1, 2, 3, 4, 5. So 5 stations examples of what we do, and again, that's the intro video there. If you don't mind, I need you to scan this QR code and leave any feedback. Okay, I always do this after any session I do. Any feedback would be appreciated. Any comments, any suggestions. For those, it doesn't matter if you actually are sitting the course or not. I don't mind. Any feedback, let me know, any suggestions, any requests. Let's say you want me to, start the course a bit later or change the course time, whatever. We'll discuss all of those. That would be very appreciated. Someone has raised their hand. Someone has asked. Kulkarni Bina, written exam in June 24. So I would wait. So if you're sitting the written in 24, that means that you're not looking into sitting the exam, the oral exam, hopefully if you pass the written at the end of the year. So I would suggest waiting a bit. But I'll keep the group open. So the WhatsApp group that we've got now, which is the Part 2 oral FRCOphth revision, that will be open. I wouldn't close this group. So any questions, you're more than welcome to ask on this group. Has anyone got any questions for me at this point? No questions.
Hi.
That is great. Yes.
Hi. I'm Romana again.
Hi, Romana.
Yeah. I just wanted to ask, it's a bit early, but will we have any break around Eid or the end of Ramadan?
That is a good question. Because the exam is in April, so that is after Eid. Yeah. We can, but if that's the case, because again, I've done a bit of the sort of weeks counting, and if we're going to start, that's why I want to start on the 16th, next week, because you will get that odd week that, it's Christmas holidays or after Ramadan, where people want to take a break. I'm very flexible, okay? So let's say even if people on the group want to take a break, I'm more than happy to take a break, but then we'll need to take another day for the mock exam. And it will be tricky to fit it during the week because everyone is working. So, and again, the time difference. So that would be of a struggle. And that's why I'm just saying I would personally prefer to start early, just in case we have this odd week or two that we need to take a break from. I'm sure someone will feel sick, someone will have some other issue. I might be sort of, unavailable sometimes. So if that's the case, we need to fit it in somehow during the week. And as I've said, in general, we'll just have to go with the majority. So whatever the majority agrees on, we just have to go through that. I think with time, if the group is huge and they actually split into those things, the FRCOphth and those splitting in the FRCS, we can split it into the courses. I'll see what I can do. Maybe I can't promise, but we'll see. We'll see what happens. Because imagine it's not easy. It's not easy. Okay. The others who joined me before will tell you it was very, very hard work. It's not easy to focus just 4 hours doing the course and speaking a lot. It's not easy. So we'll look into that.
Sorry to interrupt. I do have a suggestion. If it's possible, we have a lot of participants here. If we actually don't know about each other, maybe I don't know how many of these are giving FRCS and how many of these are in FRCOphth. So if we can categorize, and then we will know, and we can make some buddies and trying to know each other. Yeah.
Exactly. So again, if you want to, I can come up with a voting poll on the group. That's fine. But I'm talking about so the group that we've got now. That's lots of people actually not even setting the part 1 yet. Yeah. So there are lots of people who wanted to join us and just attend this session just to get an overview, which is fine. So not everyone on the group has actually, is actually planning to sit the exam. Some people have already passed the exam and they're still in the group, which again, I don't mind. Once we actually start the course, there will be a separate group, and then we'll get a better idea of how many people that we've got, and then we can split them if necessary. I'm not expecting, honestly, I'm not expecting hundreds of people to join. Yeah. But at least if we think, especially if the participation is affected. So the worry is, because so the previous exams, we had like more than 100, for each mock exam. So people were missing on participating, and some people were actually over excited and were offering to discuss more than one case. So when it's a proper course, I think we need to limit the number of people participating, so everyone has got a chance, basically. Yeah. So I'll try and at least, if we can get every single person to discuss a case every time, then that would be great. If the number is too big and then we find that, some people are complaining that, I haven't had the chance because there are lots of people, then at that point, I think we need to split it. But only time will tell, because lots of people have sort of texted me, and I do not have a proper number in mind now. So over the next week, we'll decide. Barinder, that's okay. Barinder had, and Isra Ali.
Yeah, hello, hi.
Hi.
I just want to ask a question, if it's possible.
Yeah.
What is the difference between the 2-month and the 4-month in your courses?
So it's just the amount of mock exams. So the number. Yeah. So again, with 8 mock exams. So again, remember that I'm not going to split the courses. Yeah. So the courses is running. So the course is continuous, because some people are actually sitting like the FRCS in June, or they're sitting the the local Malaysian exam in May. It's different exams, and people are coming in and out continuously. So it's running. It will have the odd sort of break every now and then, but it is continuous. You are very flexible to join whenever you want, according to when you're sitting the exam. Some people do not want to sit the exam now, so I don't think there's a point in sitting the course now. Others are quite keen just for their own knowledge. They want to improve their knowledge, and even if they're not sitting the exam anytime soon, they want to join. That's fine. The main difference is the number of exams. So 8 is obviously 2 months, and then 16 is 4 months. So every week. The quality of the talks will be the same. So it's discussing random cases, and every exam will have some very important cases and less important cases. It will have new cases. It will have. I usually go by the blue book, the Vyvanowski one that I've showed you before. It's quite good. But then I've got lots of feedback as well from previous cases and previous exams with new cases that came up. So I always try to include those as well. So if you join, let's say you want to join after a month or 2 months with the 8-week course, it's up to you. If you want to extend, that's another option. Or if you'd like 16, let's say you've got 1 month only till the next exam, but you want to watch the previous ones that you've missed, you can always get the 16 ones. I'll send you the previous ones that you missed in addition to the live ones. So to answer your question, it's just the amount of the material. That's it.
Okay, so the mock exam is a 1-to-1, but the course is a group study.
No. So the mock. So again, maybe I'm not as clear as I should be. So the previous. That's okay. That's okay. So the mocks we've done before are the same mocks that we're planning to do now. They're different cases. It's not going to be copy paste. Yeah. But they're recorded. So the ones that I've done before, these are recorded. I've got them there. I've got the data. Whoever wants to watch them, that's fine. They can get them from the website, and then I can send them the links. They can watch them. The live ones will be from next week. These are the new ones. Okay, so those will be the ones again in the group. It's not 1-to-1. It's a group. So I cannot do 1-to-1. Yeah.
Yeah.
Because imagine I cannot do 1-to-1.
Exactly.
Yeah, but it's 1-to-1 in a sense that you're discussing the case. So okay, we'll do the anterior segment. It's a Fuchs dystrophy case. Who wants to take this one? And then you'll offer I'll take this one, and then you'll go ahead. And then as you go commenting on the case, I'll ask you questions. I'll tell you should do this, you should do that. And it's very similar to the sample videos that I've put on the website and on YouTube. And then usually what happens is, a discussion sort of comes up, and then someone else raises a hand. They give another opinion, that sort of thing. That's the beauty about it. So I would really suggest participating. Some people are just shy. They don't want to participate. I think you're missing out a lot. That's the reason you need to enroll on the course, not just to watch the video. You need to participate. You need to take part. That's how you learn, basically. Some people are shy. They don't want to miss, something obvious in front of everyone. But honestly, who cares? I'd rather you miss something now
In the course or
exam.
then
Yeah,
the
then in
exam.
the exam. Yeah.
You had really good notes for the do's and don'ts, and I'm just asking, when would we be able to know the venue of the FRCOphth exam so we can, think about preparing and maybe booking something there?
Yeah, so everything is on the website. So the venue and the times are all in. So the calendar of so are you planning to set the FRCOphth yourself?
Yes.
Which exam? The part 2, the oral.
Yes, the orals for April. So
Fine.
it's just the dates, but not the venue. So
Yeah, so the
I
venue is
didn't
in
know where
London.
to book.
So it's in
Yeah,
London.
I know.
So obviously, in the website, it's in London, and the course will be every week on MS Teams. We'll have lots of people from the UK. We've got lots of people from India. We've got lots of people from Malaysia. It's all over the place. So I think time-wise, we'll have to be around this time, because I think in Malaysia now it's like 10 p.m. or something. So it's like a 8-hour difference. So we cannot make it later through the day, unfortunately. So unless we don't have anyone from Malaysia, I don't mind. But it depends on how many people are in the course. It wouldn't be fair if someone from elsewhere would not have the chance to, or like wakes up at 3 a.m. in the morning or something. I don't think it's fair. So we'll have a chat about that in the group, in the private group that we're going to do. Once I get a number of people joining, and then we'll discuss that. But yeah, so back to your question, the dates, the venues, everything is on the website. I'm not sure when the application. I think the application has opened already. I'm not sure.
It will open on Monday.
Yeah, so I think I would suggest everyone sort of enrolling on the website straight on the college website for the exam, because I think they've got 160 slots or something. I'm not sure. Everything we mentioned on the website, on the college website. Those who are still waiting on the written, they will just have to wait. I think hopefully next week or in 2 weeks' time, they will get the results. And then once you get the results, I would suggest do not wait until next year to sit the exam. You've got all the info in your mind now. Straight go to the oral exam. That would be my suggestion. No one waits. Just do it, unless you've got very, very good reason not to. Just enroll for the exam, for the next one. Do not wait, okay? Because what happens is that you'll get lazy. You will forget what you've recently read. It just doesn't help. So I'd suggest just go straight to it.
Thank you for answering.
Good evening. It's Barinder.
Hi.
Sir, I'm an overseas FRCS Glasgow aspirant. I had just cleared my part 1 in September. So I'm planning to sit for part 2 next September 2024. So I just want your suggestion on the fact that will that be too early for me to keep myself enrolled for your courses, or will that be actually beneficial during preparation for the part 2?
So you're talking about the part 2 written, aren't you? Is it the problem solving one? Or the oral?
No, I have to sit for the problem solving part 2, FRCS Glasgow.
Yeah, and honestly, and it's in September. I think it's too soon. I think for those,
my query is that will joining this practical whole thing exercise will help me in part 2 written?
It will definitely help you, because you've got a problem solving part in that written exam. So it's exactly what we do, but unwritten. So you've got a scenario, and then you write down the answers. So in a way, it will definitely benefit you, not just for the exam. It's for your clinical practice as well. However, I don't want you to sit the course now, and then when it's actually time before your oral exam, then you'll say, oh, I've sit this course before, I don't want to repeat it. Do not do this. So I'd suggest, obviously you're more than welcome to repeat it if you want, but the best benefit would be before your oral exam, okay? And again, I cannot promise you if the number is huge, not huge, but if it's a big number of people joining, I cannot give you priority. That's the problem. So I will have to give priority to those sitting in April first, and then we can, we'll see what happens.
That makes sense. Thank you.
Yeah, so do not rush, okay? Do not rush, and take it step by step. I think you've still got time.
Thank you.
Shakil?
Hi, Mustafa.
Hello.
I'm Shakil. Yeah, thank you so much for doing this talk and conducting these courses. These are very helpful. But my question is regarding the payment of these courses. I mean, will I be able to get any receipt so that I can claim the study budget?
Yes. So once you pay for it online, you'll get a email saying payment done, and then you will get another email confirming the thing. So we sort of approve you getting under the course, and then you get another email. But I can't remember which email will say the receipt. Do you practice in the UK?
Yeah.
Yeah. So that is a question that I cannot answer. Will you be able to claim for it as a study or not? Because lots of
I think if we can get some sort of evidence, then that should be enough to
I mean,
claim
I'm
the
happy
study.
because again, someone else has told me, you could apply for CPD points on the college. I haven't explored that yet because they do that for sort of big courses, and they do that for conferences and stuff to be sort of recognized from the college. Yeah. I haven't explored it, I have to say. But I am until then, I'm happy to obviously send you an email or write you a letter or whatever, confirming that you've done that course and how many hours worth you've done, and you could always claim for it, and you definitely have a receipt sent by email.
That's
definitely
perfect. Thank you.
Yeah.
Thank you.
Hi, Mustafa. It's Patrick.
Hello, Patrick. Hi.
I just need a bit of clarification about enrolling for this course.
Do
we enroll for the mock exams separate from the course itself, or is the mock exam part of the course?
So the mock is the recorded previous ones we've done. So those are for people who cannot join us for the course. Yeah. So some people do not have the time. Some people are, they cannot commit to weekly sort of courses. Then they've got the option to watch. So you can purchase the previous ones that we've done and just watch it recorded. Yeah.
Okay.
It's quite useful still, but obviously not as useful as the live course. So it's either this or that. You can do both. You're more than welcome, because the cases will not be repeated. Obviously, the topic will be repeated, but not the actual video. It might be the same sort of odd picture, the same picture or something, but it will be a different scenario. So let's say, we discussed before a pupil involving third. Now we're going to discuss a non-pupil involving third.
Yeah.
For example. Yeah. So we'll try and because if you do the math in your mind, so it's 16 exams, and then with each exam, let's say the neuro cases, at least 3 cases each exam. So 3 times 16, that's like 50 cases neuro. So does actually ophthalmology have 50 cases of neuro? No. So things will be repeated more or less, but with different scenarios.
Yeah.
Or different videos or different.
So for instance, if I book your 2 months course, how many mock exams, live mock exam would come with that?
8. So it's 8. So one every week.
Oh, I see.
Yeah. And as your colleague was saying that, that we might get this sort of, it should be continuous, but we might get this sort of odd week where we cannot do one exam in that week. So, I'm sick, or we've got Christmas, or we've got, Eid or Ramadan or whatever. There will be circumstances that we can sort of be flexible and not make it on a weekend, maybe during the week. So we'll have to discuss that privately in the course. So we'll just have to go with the majority.
Okay. All right. Thank you.
Yeah. Anyone else? No one else. I think we can call it a day.
Hello.
Who's that? SR.
SR, yes, sir.
Hello.
Hello, hi. So I wanted to ask about the guidelines part. So do we need to read each and every guideline, mention how to approach the guidelines part as an overseas candidate?
So how many guidelines are there in the college? I think there are like maybe 80 or something. You will not be reading 80 guidelines.
Okay.
So you will find some very important guidelines, which are the obvious ones. So, AMD, diabetes, glaucoma, those very obvious ones. And as I said, with each guideline, there's a summary next to it. So do not spend, again, if you've got all the time in the world, that's fine. You're more than welcome to go through the whole guideline, but you will get lost. And you'll find that actually most of that info on the big guideline document is actually repeated in the textbooks. That's actually where they got the info from the guideline. Yeah. If you're sort of preparing for the exam and you want the summary, just read the executive summary. Most of the guideline documents have got a summary to them. You just go through that summary. That's the important bits, relevant bits. Yeah. Some guidelines are totally irrelevant. So there is guidelines on how to, I think, like restore the glaucoma service after COVID. Is that relevant to the exam? Not really. It might be. I mean, again, I cannot promise what would they sort of come up with, in the exam, but you have to sort of be a bit sensible in choosing which ones to actually memorize. Like, for instance, there is a guideline on how to do immediate bilateral sequential cataract surgery. Yeah. So this is a very hot topic, and it's very debatable. It might not be that common outside the UK, but in the UK, again, to help recovery after COVID and the numbers and so on and so for the NHS, it's becoming very popular now to do bilateral cataract surgery on the same day. So this is a hot topic. You need to read it well, for instance. Yeah. So the answer to your question is it depends on the actual guideline. As we go through, we will come up with a list. It will come up with the stations, as we say, and then there are lots of guidelines in my mind that you cannot go to the exam without them. And we will go through them. That's fine. I don't mind. And that is another thing that I want to mention. Thanks for bringing that up. Do not rely. So for everyone out there, do not rely on the courses just to give you all the knowledge that you need. Okay? Because remember, it's an exam, so it's like a very quick turnover, high turnover practice. It will give you the exam feeling, but not all the info that you need. So you need to study as well. You need to go through the time to go through the guidelines or go through the textbooks, and more importantly, practice on your own time as well on patients in the clinic on your daily practice. So doing just a course is definitely not enough. It's the same for any course. It's the same for the London Eye course or Oxford or any other course. It helps, definitely helps doing more practice, but it's not enough. You need to do more on your own time. You need to spend the time doing other stuff. Okay. But guidelines is very important. I think it's more important than the trials, I think, because the guidelines are based on the trials. So, and they're quite good. They're actually quite useful. So again, I always like to, advise people that, actually read the guidelines just for your own practice, not just for the exam. Do not go into these exams because you just want to pass and get the title after your name. It's for your own practice as well. It definitely helps.
Okay, sir. Thank you.
No worries. Fine.
So even the clinical guidelines and the ophthalmic service guidelines, quality standard guidelines, everything we have to, let's say, see what is important and then read it.
Again, it depends. So, okay, so let me, just give me 1 second. We've got some time. FRCOphth guidance. I'll give you a few examples, okay? FRCOphth guidance, standards of guidance. So again, I'm now going through. So one guidance is cataract surgery in patients living with dementia. Yeah. So is that a guidance? Not really. Would they might ask you in the communication skills station, for instance, that patient has got dementia. How would you manage this patient, consenting this patient? So that is a totally different topic. It might be relevant to this guideline, but the how they asked about the guidelines, so they're not going to ask you straight ahead, tell me about the guidance about dementia and cataract patients. It's not going to be like that. Yeah. But they might ask you in a different way. Yeah. So you need to be sensible with which guideline you read. Cerebral visual impairment, CPP. I don't think that's useless. I think that is useless. Idiopathic epiretinal membrane. Not really. Cataract national data, set specification. Extremely important. So NOD, so the National Ophthalmology Database, that is very important. Okay, so that's the annual audit that all the surgeons in the UK do, and then it's automatically uploaded on the on the system, and then we get a national rate of the PCRs, the endophthalmitis, the trainees rates, the consultants rates, and then they set a standard. Again, that's a question in the Viva that it needs to be, read well. Diagnostic pathway following child vision screening. I have no idea what that is. Managing nystagmus in childhood. Again, that would just be repeating stuff that we will mention about nystagmus, how to manage nystagmus, visual support, ways to improve their vision, those sort of things, support at school, those sort of aspects. Yes, so intraoperative antimicrobial prophylaxis in elective cataract surgery patients, extremely important. So as you go through, you will notice that there is very important things, not so relevant things. Referral pathways for adult ocular tumors, very important. Management of angle closure glaucoma. So just having a general read, you will get a feel of what is actually important and what is not. And again, I'm happy, even if you're not sitting the course, you could always text me and then ask me about this guidance. Do you think that's an exam question or not? And I'll try and help. That's fine. Okay. Managing an outbreak of post-operative endophthalmitis, very important. So yeah. Fine. Okay. I think if no one else has any questions, we'll call it a day. Please do the feedback. For those who are keen to join, I would enroll this week. There is no rush, but I will start on next week. I will do a voting poll as well, and then we'll kind of decide if we're starting this week or the week after that. I would suggest starting on the 16th, just in case we miss out on a week or so later, and then we just be on the safer side, especially for those sitting in Pakistan or Singapore as well. There's a few exams coming up in February and March, I think. So we'd rather do it early rather than later. I think that would be the smart way to do it. Okay. Thank you, everyone. Thanks for your time. And I hope to see you soon on the course. Have a good day.
Thanks a lot.
No worries.
Well, thank you.
Take care. Bye.
Thank you very much.